Welcome to Roadmap to Residency. Hello everyone, I am Aviras. Welcome to our Club to 50 matchmaking sessions. We are currently in our nephrology modules and we will be running through some questions with you guys to help you on a journey to a 250. So which of the following factors is most likely contributing to the development of essential hypertension in this patient? A 42-year-old woman is being evaluated for high blood pressure during a routine checkup. She has no significant medical history and is not taking any medications and denies any symptoms. On examination, her blood pressure readings on multiple occasions are consistently elevated. Lab tests, including renal function and electrolytes, are within the normal limits. The patient's family history is notable for hypertension in both parents. Which of the following factors is most likely contributing to the development of essential hypertension in this patient? Chronic kidney disease, primary hyperaldosteronism, family history of hypertension, pheochromocytoma, or Cushing's syndrome. So essential hypertension is influenced by both genetic and environmental factors. A positive family history of hypertension is a significant risk factor for the development of essential hypertension. Genetic factors play a role in determining the blood pressure set points, and individuals with a family history of hypertension are more likely to develop the elevated blood pressure. Now, we have discussed hypertension in detail, also the treatment of the hypertension in detail in the cardiovascular system. Here, we are only discussing about some of the basic criteria which are needed to be fulfilled while reading the nephrology system. So definition of hypertension, a BP of more than 140/90 on two separate occasions, and if there is an in-organ damage, diagnosis is made on the first visit. Now, hypertension is not diagnosed until two separate measurements on two separate occasions are above 140/90, except in pregnancy, when preeclampsia may be a cause of hypertension. Also, if hypertension is severe, more than 210 or more than 120 in the diastolic phase or in inorganic effects, immediate treatment with medication is warranted. So talking about the JNC classification of hypertension. So the normal is less than 120/80. Pre-hypertension is 120 to 139, and it's diastolic being 80 to 89. Stage 1 hypertension is 140 to 159, and diastolic to be 90 to 99. Stage 2 hypertension is more than equal to 160 or more than equal to 100 diastolic. The causal conditions of hypertension is maybe it may be primary or essential hypertension in 95% of the cases, or it may be secondary. It can be due to renal or vascular. It can be due to uh, polycystic kidney disease or renal artery stenosis. It can be due to endocrine causes, or it can be due to hyperthyroidism and adrenal adenoma, which can increase aldosterone and increase the cortisol. Also due to the pheochromocytoma and hyperparathyroidism. So some of the reversible risk factors include obesity, poor dietary habits, high sodium intake, sedentary lifestyle, okay, coffee consumption, mm, high stress, high normal BP, illicit drug use, and horrible medications. So the target organ damage and hypertension. In case of cerebrovascular system, it can cause transient ischemic attack, ischemic or hemorrhagic stroke, and vascular dementia. It can cause hypertensive retinopathy. It can cause left ventricular dysfunction, MI, angina, congestive heart failure. It can also hit the kidney and cause hypertensive nephropathy and albuminuria, and the peripheral artery disease. It can cause intermittent claudication. Now, the exogenous aggravators of hypertension may be some drugs like NSAIDs, OCPs, and sex hormone, corticosteroids and anabolic steroids, vasoconstricting drugs. Okay, now EPO analogs, midodrine, other may be salt. Okay, sleep apnea, licortisol. So urinary albumin secretion, identify urinary albumin secretion for DM and CKD, and treatment differs without proteinuria. Albumin by, albumin by creatinine ratio more than 30 milligram per millimeter mole is abnormal. So there are some lifestyle therapies in hypertension, which can be reduced food with sodium added, which we need to consume sodium less than 100 millimole per day. Weight loss, okay, and exercise, dietary patterns, smoking cessation, waist circumference. So there is something called as the DAS diet, right? Now, the diet is called the dietary approach to stop hypertension. So if the patient does not have symptoms and is a new case of hypertension, then we don't start the therapy alone, and we just go with the dietary approach to stop hypertension, and consequently we go on adding the drugs if it is not controlled. Hypertension in elderly. A BP of more than 140 upon 90, isolated systolic hypertension, that is systolic BP more than 140, is more common in elderly population. The prevalence may reach 60 to 80% if the patient is 60 years or older. So factors that contribute to increasing the prevalence of hypertension in elderly include decreased compliance of arterial wall, decreased anode-dependent arterial vasodilation, decreased number of functioning nephrons, increased collagen and increased vascular thickening, decreased elasticity, and decreased cardiovascular physiological reserve. So which of the following condition is most likely contributing to the development of secondary hypertension in this patient? A 35-year-old woman presents to the primary care clinic with complaints of headaches, palpitations, and episodes of sweating. She reports occasional episodes of rapid heart rate and is concerned about her blood pressure. On examination, her blood pressure is significantly elevated, and the patients deny any family history of hypertension. Lab tests include renal function and electrolytes are within normal limits. Which of the following condition is most likely contributing to the development of secondary hypertension in this patient? Essential hypertension, chronic kidney disease, hyperthyroidism, Cushing syndrome, or primary hyperaldosteronism. So hyperthyroidism is a potential cause of secondary hypertension. Excess thyroid hormone can lead to the increased cardiac output, heart rate, and peripheral vascular resistance, contributing to elevated blood pressure. Symptoms such as headaches, palpitations, and sweating are consistent with the clinical presentation of hyperthyroidism. So these are the causes of secondary hypertension. These include metabolic syndromes like dyslipidemia, insulin resistance, the renal parenchymal or renal vascular disease, obstructive sleep apnea, preeclampsia and eclampsia, neurogenic causes like acute increase in intracranial pressure and acute spinal cord section. There are some endocrine diseases like pheochromocytoma, Cushing syndrome, Conn syndrome, acromegaly, hypothyroidism, and hyperthyroidism, coarctation of the aorta, Mendelian forms of hypertension, and iatrogenic like hormonal or oral contraceptive and NSAIDs, and some drugs like midodrine. So, which of the following over-the-counter medications is most likely contributing to the development of secondary hypertension in this patient? A 55-year-old man with a history of hypertension presents to the primary care clinic for a medication review. He reports good compliance with his prescribed antihypertensive medication, but mentions that he recently started a new over-the-counter medication for chronic back pain. On examination, his blood pressure is significantly elevated compared to previous visits. Which of the following over-the-counter medications is most likely contributing to the development of secondary hypertension in this patient? Acetaminophen, ibuprofen, naproxen, diphenhydramine, or pseudoephedrine. Now just pause the video and think what is the answer. So pseudoephedrine is a sympathomimetic drug which is commonly involved in the over-the-counter decongestant. It can lead to vasoconstriction and increased blood pressure. Patients with a history of hypertension should use caution when taking medications containing pseudoephedrine, as it may contribute to the development of secondary hypertension. Acetaminophen is not known to cause significant changes in blood pressure. Ibuprofen, so NSAIDs like ibuprofen can cause sodium and water retention, potentially impacting the blood pressure, but they are not as likely to cause acute increase in the blood pressure. Similar to ibuprofen, naproxen is an NSAID and may contribute to the fluid retention, but cannot acutely increase the blood pressure. Diphenhydramine and antihistamine may cause sedation, but is not a common cause of hypertension. So you need to check the accuracy of blood pressure measurements, rule out diet and drug-related causes. After that, we go for the history, physical examination, lab testing, ECG, urine analysis, fasting blood glucose, hematocrit, electrolytes, creatinine, glomerular filtration rate, and calcium or lipid profile. So we need to rule out all the causes of secondary hypertension, and then you need to treat the patient as a case of primary hypertension. Because if you have not ruled out the cause of secondary hypertension, then if you do not treat the cause as a whole, then the hypertension will not be controlled and will cause significant damage to the life of the patient. So no clinical clues, but secondary hypertension remains a concern. Example, in a child, rapid onset or acceleration of hypertension or resistant hypertension. Then in case of child that is birth to 18 years, there may be the coarctation of aorta or renal parenchymal disease as a cause of secondary hypertension. So for that, we do the urine analysis, urine culture, and renal ultrasonography. In young adult, there may be thyroid dysfunction or renal artery stenosis secondary to the fibromuscular dysplasia. So in these patients, you go with MRA angiography with gadolinium contrast media. We also go for the CT angiography and thyroid stimulating hormone, or you can say the thyroid function test. And at last, we go for the echocardiography too, if cause not found. Then in the middle-aged adult, for the 40 to 64 years, there may be differences like hyperaldosteronism, obstructive sleep apnea, Cushing syndrome, pheochromocytoma. Then we can find the renin and aldosterone level in the patient, and we also go for the thyroid function testing. Polysomnography may be included if we cannot find the cause from this, and if even if we cannot find any cause with CT, polysomnography, or hair, then we go for the 24-hour urinary free cortisol or 24-hour urinary fractionated metanephrines. In older adults, renal stenosis is one of the most common cause, along with the renal failure. We go for renal artery Doppler, ultrasonography, MR angiography with gadolinium contrast media, CT angiography, thyroid function testing, and urine analysis. Again, if we cannot find any cause, we go for the 24-hour urinary free cortisol and 24-hour urinary fractionated metanephrines. Now, which of the following is a common consideration in the management of hypertension in elderly patients, particularly to avoid orthostatic hypotension? An 80-year-old woman presents to the geriatrics clinic for a routine follow-up. She has a history of well-controlled hypertension and is compliant with her antihypertensive medications. Lately, she has been experiencing episodes of dizziness and feeling lightheaded, especially when standing up from a seated position. On examination, her blood pressure is 140/90, and while seated, it is 110/70. Which of the following Upon standing, now which of the following is the common consideration in the management of hypertension in elderly patients, particularly to avoid the orthostatic hypertension? Aggressive blood pressure lowering, initiating high-dose diuretics, rapid titration of antihypertensive medications, avoiding medications with central alpha agonist activity, and prescribing beta blockers as a first-line therapy. So avoiding medications with central alpha agonist activity. So orthostatic hypertension is a common concern in elderly patients, and medications with central alpha agonist activity and can exacerbate this issue. And medications such as clonidine, methyl dopa, and centrally acting alpha agonists will be used cautiously in the elderly to minimize the risk of orthostatic hypertension. Thank you for watching. Keep studying hard.